Hey everyone, and welcome to today's Explainer. We are jumping right into a premium, high-yield clinical breakdown of a condition you're going to see literally all the time in clinics and emergency departments, and that is laryngitis. I'm absolutely thrilled to take you through this material today because, despite how incredibly common it is, it's also incredibly prone to mismanagement. So we're going to clear up the confusion, look at the hard evidence, and give you the exact framework you need to approach this confidently. Okay, let's dive right in.
To make our learning as efficient as possible today, here's a quick look at our roadmap. We'll start with definition and anatomy, move into acute versus chronic etiology, cover the hallmark clinical features, discuss investigations and red flags, and then finally wrap up with evidence-based treatment plans.
All right, starting off with Section 1, Definition and Anatomy. Let's establish our pathological baseline.
So what exactly is laryngitis? Quite simply, it's the inflammation of the larynx and the vocal cords. When we talk about symptoms and treatments a bit later on, I really want you to picture these swollen, inflamed vocal cords that just can't vibrate cleanly. Every single clinical decision we discuss today ties directly back to this localized inflammatory process. The edema basically disrupts the normal aerodynamic flow and the mucosal wave mechanics required for phonation, which is precisely why your patient sounds the way they do.
Moving right along to Section 2, acute versus chronic etiology.
Look at this statistic. More than 80% of acute laryngitis cases are strictly viral. We're talking about the usual culprits here: rhinovirus, influenza, parainfluenza, and adenovirus. I really want to drill this home right now, because this single, undeniable stat completely dictates why certain treatments work and why others fail miserably. When a patient walks in with a sudden loss of voice, it is overwhelmingly likely to be a viral invader. Understanding this viral dominance, that's your primary shield against unnecessary prescribing.
Now, beyond our heavy-hitting viruses, acute triggers can also include things like sudden vocal strain, sudden allergen exposure, or acute smoke inhalation. But we've got to contrast those with the more insidious chronic causes. Gastroesophageal reflux disease, and specifically laryngopharyngeal reflux, or LPR, is a major chronic driver, and it often presents without any classic heartburn at all. We also see chronic smoking, ongoing vocal abuse, and importantly, fungal infections. Those absolutely must remain high on your differential for immunocompromised patients, particularly those using inhaled corticosteroids without a spacer.
Which brings us to Section 3, Hallmark Clinical Features. Listen, if you take absolutely nothing else away from this clinical presentation, please remember this. The absolute hallmark signs are hoarseness and dysphonia. Those inflamed, edematous vocal cords simply cannot produce normal sound. They completely lose their pliability, and in severe cases, this progresses all the way to complete aphonia, literally a total loss of the voice, which, as you can imagine, is highly distressing for the patient. Now, these voice changes rarely happen in total isolation. You're commonly going to see supportive symptoms like a sore throat, a dry cough, and a globus sensation, which just presents as this persistent, non-painful, kind of foreign body sensation in the pharynx. But pay really close attention to the pediatric presentation. In kids, laryngitis frequently presents with stridor and croup. Because children have fundamentally smaller airways to begin with, subglottic inflammation leads to significant airway narrowing and increased resistance, and that produces that classic, high-pitched inspiratory stridor.
Okay, I need everyone's full focus here because this is a massive clinical warning. Fever is rare in standard laryngitis. Let me repeat that so it sticks. Fever is rare. If you have a patient presenting with hoarseness and a significant fever, that is a glaring red flag. You must immediately suspect epiglottitis or another severe, potentially airway-compromising infection. Do not just send a febrile patient home with a basic diagnosis of simple laryngitis.
Let's pivot now to Section 4, Investigations and Red Flags.
So, for the vast majority of cases, laryngitis is just a straightforward clinical diagnosis. There are no routine labs to order, right? You don't need a blood test to tell you their vocal cords are inflamed from a cold. But that raises a pretty critical clinical question. Since routine labs aren't used, when absolutely must you escalate this and investigate further?
Well, there are strict clinical triggers for ordering a flexible laryngoscopy. First, if symptoms persist for greater than 3 weeks, it's now officially chronic and you must investigate. Second, if you note unilateral cord paralysis. Third, the presence of stridor. And finally, a significant history of smoking. The urgent need for this invasive procedure in these high-risk scenarios is to rule out malignancy. You simply cannot afford to miss a laryngeal cancer that's just masquerading as a stubborn case of chronic laryngitis.
And finally, Section 5, Evidence-Based Treatment Plans.
Let's do some evidence-based myth-busting for acute treatment. Your frontline interventions are actually just simple supportive care. Absolute voice rest, systemic hydration, humidified air, and throat lozenges to soothe the mucosa. But just as important is what you should not do. Do not prescribe antibiotics. Like we said, over 80% of these cases are viral, making antibiotics entirely useless and a primary driver of resistance. Also, do not advise whispering. Patients think it protects their voice, but it actually forces those vocal folds together super tightly, straining them far more than normal speech would. And finally, stay away from antihistamines and decongestants. They systematically dry out the vocal cords, completely reversing the mucosal hydration those tissues desperately need to heal.
Now you might be wondering, is there ever a time for heavy-duty medications? Well, yes, but it is a very narrow clinical exception. Corticosteroids, like a short course of oral prednisone, are reserved strictly for cases of severe airway edema, or for professional performers who absolutely must use their voice for an impending, unavoidable engagement. It is definitely not for the average patient with a raspy voice from a rhinovirus.
When we shift gears to chronic treatment, the protocol maps strictly to the underlying cause. You can't just treat the hoarseness, you have to treat the root. If laryngopharyngeal reflux is the driver, prescribe a proton pump inhibitor and implement lifestyle modifications. If chronic vocal abuse is the culprit, refer the patient for formal speech therapy to correct their phonation mechanics. And if smoking is the irritant, you need to initiate a robust smoking cessation program. True resolution here requires targeted, sustained action.
All right, we've covered a lot today. The anatomy, the viral dominance, the red flags, and the targeted treatments. But I want to leave you with a final thought to really mull over. If whispering strains vocal cords more than speaking, and over 80% of acute cases are strictly viral, why are patients still leaving clinics with antibiotics and advice to whisper? It is high time we align our everyday clinical practice with the evidence. Thank you so much for joining me for this explainer. Keep these protocols in mind during your next shift, and I'll see you next time.